Bismillahirrahmanirrahim. Assalamu alaikum. Good morning, everyone. I am Dr. Sidra Liaquat, resident at Virology department. Today, I am going to discuss about a case that will highlight the importance of post-renal transplant complications due to BK virus deactivation. Coming towards our case, a 24-year-old female with a history of chronic renal failure. She had been on dialysis for 2 years before undergoing a renal transplant for 1 year ago. Recently, on routine PCR and post-transplant monitoring on quantitative PCR for BK viral load, her high BK virus load was detected on his both urine and blood samples through PCR screening. It was accompanied by a rise in serum creatinine levels. On renal biopsy, there was confirmation of viral cytopathic changes for BK virus. We received both samples of this patient for the quantification of BK virus in her both blood and urine. As you can see here in the report, we received on February her BK viral load was very high in plasma. So very high level of viremia was detected. That was 58,000 plus copies per ml. And in urine we received it and we perceived it for quantification of BK virus. And you can see here the number of copies are 361 plus million copies per ml in her urine. When the patient was sent her samples for the screening, she was on immunosuppressive agents tacrolimus and prednisolone. After releasing of this report, we discussed this case with her doctor and detailed information was taken and his history was also taken. The biopsy report was not performed at our lab, so he declined to give us his report. But we have his PCR reports, and on the quantification of this higher viremia, her patient declined and reduced the immunosuppressive regimens, or that was tacrolimus, and rapidly reduced the levels of prednisolones. Then we again received after a month, as you can see here on March, we received both samples, plasma and urine, to quantify the viral loads in both her blood and urine. And you can see here that her plasma level in previous slides were 58,000 plus copies per ml, but after taking the immunosuppressive drugs, her levels reduced to 44,000 copies per ml. As well in urine, also copies or reduced viral copies from 360,000 millions plus to 125 million copies per ml. So at the time of diagnosis, the patient was also on other modulatory therapies with these screening tests, and in a collaboration with us, her condition improved. We also called her in the last month, and in this month also there were little chances of graft rejection, and she was improving. You can see here on the graph there is a comparison of quantification of this PCR. It shows a viremia and virulia both here. You can see. Now coming to what actually the BK virus is. BK virus is a small non-enveloped DNA virus. It belongs to family Polyomaviridae and genus Polyomavirus. It is small, having a diameter of 40 to 45 nanometer. It has a genomic size of 5 kb and it contains 72 capsomeres. You can see here the genomic structure of this virus. It is very important. On the top you can see here it is NCCR. It is non-coding control region of this virus. It is very important in transplant patients because mutations take place at this region. On the left side you see here antigen encodes small t antigens and large T antigen proteins. These large T antigens have a very crucial role because they have propensity for RBG and P53 gene, and it is involved in the immortalization of the cell, and it is also involved in the latency phases of that virus. And late regions, you can see here it encodes VP1 capsid proteins, VP3 and VP2. These are important in the replication steps of the virus. BK virus was first identified in 1971 by Gardner and his colleagues from the urine of a renal transplant recipients whose initials were from the patients from where this virus was isolated. The virus is named after this index patient. First biopsy-proven case of BK virus nephropathy was reported in 1993. High rates of graft loss, about 50 to 100%, were associated with BK virus nephropathy in the early reports, but with improved screening, diagnosis, and management, it has led to a decrease in the graft loss. So, important things which we have to discuss today, and that is important point that this viral replication can lead to the graft loss. Monitoring, screening, and proper immunomodulatory therapy balance is also very important. We will discuss later on in next slides. BK virus is ubiquitous virus with a worldwide seroprevalence of approximately 80 to 90% of population. And 80 to 90% of population at the age of 4 acquires this virus, and they develop the antibodies against this virus, and these levels are detectable throughout their life. Primary infection is acquired during childhood. Possibly it is transmitted through fecal-oral route or through respiratory transmission without noticeable symptoms, or just like upper respiratory tract like mild symptoms like flu, cough. It establishes its latency infection in genitourinary tract. That is very important because here it reactivates and replicates, which results in the graft loss, particularly in neuroepithelial cells and renal tubular epithelial cells, and then in the tubular cells after reactivation in transplant patients. Reactivation takes place in the individuals who have immunocompromised systems, such as transplant recipients, where it can cause a range of clinical syndromes. Its reactivation also takes place in other solid organ transplants, but it is rare, like in bone marrow transplants or liver transplants, but it is rare. And approximately 1 to 10% of renal transplant recipients, they develop BK virus nephropathy, which is associated with graft loss. As I have mentioned previously, that with proper screening, this graft loss has reduced from 50% to 10%, 1 to 10%. Now, coming toward the host immune defense, it is a very crucial. Host defense system of every person is very crucial to control the viral infection, replication, and reactivation. This diagram shows the how a latent BK virus reactivates in the kidney and causes the nephropathy. In first kidney picture, you see it is a healthy kidney of a person who is immunocompetent. He has there is a lot of and complete set of T cells which can clear the virus successfully. If a person is immunocompetent, a latent virus in a kidney, if reactivates, it is cleared through cytotoxic T cells successfully. But in case of immunocompromised patients, when due to immunosuppressive therapy like given in the transplant patients, this immunosuppression leads to the delayed response or insufficient response of cytotoxic T cells. When antigen presenting cells presents this virus to cytotoxic T cells, these cells are insufficient or they have delayed response, so virus rapidly replicates and propagates into the renal system in tubular cells, uroepithelial cells, and it leads to the tubular atrophy, interstitial inflammation, and damage and resulting in the graft loss. On the left side, you see in this diagram, in case of acute VK virus reactivation, if it results in the low level of inflammation, cytotoxic T cells are able to control the viral replication. So, immunosuppression is safe and it is a very ideal scenario. In case of chronic replication, if there is a massive inflammation due to this VK virus and massive inflammation in uroepithelial cells, interstitium or tubular atrophy, and cytotoxic lymphocytes are less than immunomodulatory mechanism is low, then reduction of immunosuppression is harmful and immunomodulatory therapy is required. VK virus nephropathy was considered as a rare complication in renal transplant patients in early years. But because at that time less potent immunosuppressive regimen was used like azathioprine and cyclosporine. But in 1995, after introducing the tacrolimus and mycophenolate mofetil, this level and rates of VK virus nephropathy increased. The occurrence of VK virus nephropathy, it is not due to any specific immunotherapy or immunosuppressive agents. The basically important play role is the regulation of the degree of immunosuppression. This virus has a tropism, a great affinity for uroepithelial cells because every virus requires a specific receptors for its action. So, this virus has a specific gangliosides in uroepithelial and tubular cells. So, tropism and affinity for this virus is high in tubular cells of uroepithelial cells. As viral replication begins in urothelial or tubular cells, it leads to the shedding of virus in urine, which is known as viruria. This replication takes place in 3 stages. Number 1 stage you see here is viruria. It takes place about 30 to 40% in all transplant patients and in post-renal transplant patients. It is manifested earlier in VK virus infection. This viruria is asymptomatic and it is detectable only by screening, as I have mentioned in our case that patient was detected by PCR and also her creatinine level was increased about 3 to 5. Viruria follows viruria in few weeks, most frequently in those with a higher viral load and sustained viruria. It is a very accepted indication and it receives the samples for its detection in screening test, and it is the indication to reduce immunosuppression in renal transplant patients. VK virus associated nephropathy. It is asymptomatic if in condition of patient is suffering from asymptomatic viremia, and a slow progressive rise in serum creatinine levels. They are typically the indicator of VK virus nephropathy. So, the clinical response in the patient, it depends upon the degree of viremia, immune status or immunosuppressive regimens and allograft dysfunctioning. This graph shows about the significance of that I have mentioned about viremia and viruria. In the start, patients suffer in first 3 months virus sheds in post-transplant patients in the urine. Here you can see here is only viruria in starting of the months. Then gradually this virus, if reactivates and replicates and it comes into the blood, then viremia and viruria both take place after 3 months. It is detectable both here in the screening test by a quantitative PCR. Then if it is not treated or it is leading worstly, then you can see here with viremia and viruria, creatinine levels are also raised, which shows that kidney is not functioning properly, and at here the gold standard is biopsy. It will also be positive at this stage. That will show that a initial stage of VK virus nephropathy has started. Then, if it is not controlled here, then it may lead to the end stage BK viral nephropathy and ultimately the graft loss. Other manifestations also include uteric stenosis, urothelial cancer, and hemorrhagic cystitis. Hemorrhagic cystitis is rare in post-renal transplant patients. In bone marrow transplants, it is common. BK virus also affects blood vessels, retina, lungs, and causes the inflammation and narrowing of the blood vessels. It leads to the vasculitis, and rarely it may also infect the brain and meninges, leading to the meningoencephalopathy. In retina, it causes the inflammation of retina and leading to the retinitis, pneumonitis, and it also causes the hemophagocytic syndrome. These are the other extrarenal manifestations which can also occur with this virus. Risk factors are very important in post-renal transplant patients for this BK virus replication leading to the BK virus nephropathy. Important two factors I will discuss earlier. First is donor and recipient factors. If donor is BK virus seropositive, means he has antibodies against that virus, and recipient is seronegative, he has no antibodies against the virus, it will lead to the acute BK virus replication. And if donor is in donor and recipients both have HLA-C7 absent, there will be a high risk of developing BK virus nephropathy. Transplant factors include HLA mismatches, ABO incompatibility of transplant, and episodes of rejections and ischemia or reperfusion injury is also very important. This HLA-C7, why this HLA-C7 is important? Because this HLA-C7 presents BK virus antigen to the cytotoxic T cells. It potentially influences the efficacy of viral clearance or immune tolerance. So, if diabetes mellitus with advanced age, they also contribute for the development of BK virus nephropathy. Now, coming to the screening and diagnosis of BK virus infection, post-transplant screening is very important. Routine screening is recommended for all post-transplant recipients through quantitative DNA PCR for BK virus. It is recommended in all post-renal transplant patients monthly for first 9 months, then quarterly until 2 years, then annually until 5 years after post-transplant. Or if a person is having renal allograft dysfunctioning and allograft biopsy, this span can be reduced. Different diagnostic modalities are available for diagnosis of this BK virus. I will discuss in the next slides. Number one is the urine cytology. Cytological examination of urine reveals the BK virus infected cells. It is infrequently used to screen this BK virus. It is a less sensitive modality. This utility is further limited by inter-observer variability and qualitative rather than quantitative nature of this test. Decoy cells are seen and they are renal tubular or urothelial cells. They are within intranuclear BK virus bearing inclusion bodies. Here you can see in the first picture diagram. In A you can see a urine cytology specimen which shows the decoy cells, high chromatin material and smooth nucleus. There is a ring of condensed chromatin and internuclear influence with a ground glass appearance. Here you can see the single decoy cells, these are the compacted, and in the third urine cytology there is a tubular cast along with the internuclear influence. Negative staining is used to see the viral particles in electron microscope. Here you can see it is a negative staining sample of the urine under the electron microscope. It reveals a cast of three-dimensional polyoma virus aggregates. These are known as Hoffman cells and they are formed in the injured tubules after the viral application. But this is not widely used screening test. In some settings, it may be done in case of in pediatric patients where invasive biopsy cannot be done. So this test can be performed, but it is limited to very few settings. Renal allograft biopsy for VK virus, it is a definitive diagnosis is required. Then it is a gold standard to diagnose the VK virus nephropathy. It assesses the severity and evaluate the concomitant process going on in the urothelial cells. Different. It has a staging which three stages in its classification A, B, and C, and according to the grading of that biopsy, a concomitant and the undergoing process is explained. But important thing is two core biopsies are taken because it is a there is a patchy involvement of this virus, and this virus nephropathy can be missed if that portion is not taken. So two samples are very important. Biopsy is invasive, so diagnosis is based on the presence of viremia. After high levels in viremia, and then concomitant biopsy is recommended. Here you can see intranuclear basophilic inclusions without surrounding halos. Here you can see without surrounding halos, hyperchromatic and chromatin clumping. But important thing is this biopsy is performed along with immunohistochemistry, in which a stain is used, that is SV40 stain, against the T antigen of that virus to specifically diagnose this virus. Plasma quantitative PCR, yes, now it is highly recommended. It is preferred screening test because it has high sensitivity, 100% highly sensitive, and it is 90% specific, high positive predictive value, and we recommend, as we know that we have a viral load detection limit of more than 29 copies per ml. But if person is having a viral load of 100, 200, 300, the patient is not suffering from viremia. But if a patient's viral load is more than 10,000 copies per ml, a person is definitely suffering from viremia, and he may suffer from VK virus nephropathy. In urine, it has also high negative predictive value. It tends to precede the plasma NAT test by 4 weeks and histological nephropathy by 12 weeks. Presence of positive NAT test for VK virus in the urine, but if there is no elevated level of VK virus in plasma, so it will not be associated with a VK virus nephropathy. So positive urine NAT test is required. It should be followed by a plasma NAT test. Two necessary tests are required. But unfortunately, there is no effective therapy for this VK virus infection. The standard practices protocols are to reduce the immunosuppression and monitoring to reduce the acute rejection, as I have mentioned earlier, that this prognosis has improved due to these screening tests. Several agents in different settings in few researches I have seen that they have used intravenous immunoglobulins, leflunomides, cetofovir, these are antivirals, and colonial antibiotics, but there is no established efficacy and there is no role to prevent this nephropathy in the cases of this VK virus nephropathy syndrome. However, efficacy is not established, so these are not routinely used. So important take-home message that it is very common infection. Everyone contains antibodies against this virus. Seroprevalence is very high of this virus. Everyone requires at the age of you and me. We all in this hall will have definitely antibodies of this virus latent in our kidneys. So screening and early detection is necessary to inhibit the virus. The rationalism is very important to play in between this immune system and this nephropathy. Immune response must be clearly balanced. It does not mean that if VK virus nephropathy has been diagnosed, doctors recommend a certain decrease in immunosuppression, because if there is a sudden decrease in immunosuppression or reduce the levels of immunosuppressive modalities, it will also lead to the acute rejection. So there is a balance between immunosuppressive modalities, not too much high and not too much low. Rationalism is very important. because there is no vaccination for this virus, there is no definitive antivirals for this virus. So advancement in medicine has got surprise, but we can save a life by a rationalism of proper immunosuppression, not too much and not too much reduce that a patient should be in between and balance immunosuppressive population. Thank you.